which is very close to my heart is the snake bite or snake envenomation or ophiotoxemia. So again, it's not a topic that we can discuss it over 30 minutes. So what I will do is, whatever be the time permitted by the admin, I'll just go forward and share some interesting syndromic approach, which and there are a lot of controversies to be very frank. And when you look at the pattern of treatment from institute to institute, the overall algorithm remains the same, but definitely there are some institutional variations which they develop as and when they see cases and as per their experience. They go ahead and start doing these things. So, whatever I had been since the last 18 years in emergency medicine, I had an exposure. I had the privilege to have the with the exposure of the great toxicologist Dr. V. Pillai sir and Dr. Jaideep Menon, who is the one of the pioneer in snakebite and venomation. Dr. Joseph, who is there in Little Flower Hospital, Angamali, and there are a lot of colleagues who have been spending a lot of time in managing snake venomation, doing a lot of research. One name to that we need to say is Karthik Sunagar from Bangalore. So Dr. Karthik Sunagar is doing a lot of research in snake envenomation, and that's how we are getting all this information. So from when we talk regarding snake envenomation, so that is one of the major thing. What has happened is it has become a notifiable disease. So Tamil Nadu government initially started off, but it has been taken globally throughout the India. Now it is being a notifiable disease, and state to state there are variation in giving compensation to the patient regarding what they need to be given after a snake envenomation and all those things. But I will not go into that intricacies. But what is planned for the session? Introduction, just an overview of Big Four. Maybe there are a lot of new people who have joined for our webinar and who are not much familiarized with the snake venomation. So I'll just give an overview about the Big Four and the snake venom and the clinical features. The syndromic approach is what I'll be emphasizing upon, because many a times there has been a lot of interest among doctors in identifying the snake by looking at the pictures and all. But it is good if you can have that knowledge is very good. But always it is very important that you treat the patient as per the clinical features. So just recently, couple of days back, in one of the group that we are just following, because it's one of the active group called as Kerala Snakebite Group. What we just seeing that. The patient is presented to the emergency room with features of neurotoxic and envenomation, and the snake captured and brought by the family is an rat snake. So that is again one of the important things. Looking at the rat snake, they didn't stop giving him the treatment. Looking at the syndromic approach of the patient, they started the treatment. So this is a big question, that whether we need to bring snake to the dead snake to the hospital, or we need to chase the snake and kill it and bring to the hospital. That we'll discuss meanwhile. And what are the management aspects? What are the key changes? And a nutshell about the ASV management I will give you, and the complication management. So that is what is being planned. And I should thank my colleague Dr. Shabrish, who has beautifully designed this PPT for me before. So that is what I am using. So the credit goes to him. So 64,000 death due to snake bite in India. So India accounts for almost 80% of snake bite death. So that has been the number of snake bite death. So this is maybe 3-4 year old data, but still the numbers are high. When I was in Cochin Amrita, we just had a discussion and how to bring down the snake bite death. In last year, in 2024, Kerala, we had around 35 snake bite death. So we were trying to just figure out how we can bring down. We had a lot of help from the forest officials. We have a lot of from the herpetologist, Dr. Sandeep Das and team. There has been a huge team who were supporting us in running this program, and where we have identified certain aspects which are the key information that you need to be given to the localates where the snake bites happen, where to bring the patient to the hospital. So these are all lot of gaps we have identified, and we have coming up with a position paper on it. So how to the zero snake bite death initiative. So 35 is the death number in Kerala. So we wanted to replicate the same model to other states of India, where we can significantly bring down the snake bite numbers. So you can just see the pictorial representation of how the snake bite is been affecting in our country. So that is again, it's a huge number, and you can see the high, medium, and the low. So the red being the high, and there is definitely a seasonal variation. This has been the trend, but now the season, the rainy seasons, you are not expecting it is when you are in some part of India, you have to expect that this is the rainy time, but due to the climate changes, you can't anticipate. So the patterns of the snake is also snake envenomation is also changing now day to day. So this was the pattern when studied in 2019-20. So looking at the big four, you can just look at the maximum number of cases how been reported. There are more than 300 species of snake inhabiting diverse landscape, but only few of the snakes species can cause injury due to venom. So that is what we call it as the big four. The classically we all learn it as the big four, being the common cobra, naja naja, basically a neurotoxin. Common trait, the Bungarus ceruleus venom, and again being a neurotoxin. And viperidae species, we have the two major one, the sow-scale viper, that is Echinus carinatus, and Daboia russelli, that is the Russell's viper. So Daboia russelli, when you come down south, especially in Kerala, there is an overlap of both hemotoxic and neurotoxic envenomation with Daboia russelli. And it is not just the big four right now, because there are a lot of cases, lot of cases of hub-nose pit viper being reported in and around specifically very common to see in Kerala, Karnataka, Maharashtra, Goa, and Tamil Nadu. So it commonly causes a renal failure. So it's the big five. The major problem that we face with the hub-nose pit viper is that we don't have an anti-snake venom as of now. Right now, we don't have it available. So there has been some research process going on in producing snake anti-snake venom against hub-nose pit viper. So that is not yet available in the country. So snake venom basically components, as you know, 90% is protein and lot of enzymes, hydrolases, hyaluronidase, everything, zinc metalloproteinase, which damage the endothelium. But one of the major thing you can just Google snake bite. What are the recent updates? One of the major thing what we see is lot of study has been happening in phospholipase A2. So veracipilib, there is a drug which can be used in certain condition, has been tried in snakebite victim also. Basically, the phospholipase A2 has been the culprit. So they have been trying this with this, but again, to use it in snakebite or not, it's still a debate. So the studies are ongoing, and you have to understand post-synaptic alpha neurotoxin, it can bind the ACH receptors, and there is also presynaptic beta neurotoxin, which damages the nerve ending. So cobra basically an alpha neurotoxin, and common crate being a beta neurotoxin. And again, variation based on geography, that is again a big challenge, because the all the anti-snake venom that is being produced right now, the major there is a community called as Irula community. They are in Chennai, near to Chennai, Mahabalipuram. There is a tribe called as Irula tribe. What they does, they go to the forest, they catch the snake, and they bring to a cooperative society, and they extract the venom, and they sell it to the companies, so that maximum amount of venom that is being produced from that group of snake is being used for the usage of anti-snake venom preparation. So it is not just in India. These antivenoms are supplied throughout Asia. So you have to understand that that is the major representation is from that area. So geographically, the snake can vary, and the venom also can vary. So the whatever be the representation that we are getting is mainly from the Irula community near Mahabalipuram. That is the area near to Chennai. So that community, they have a cooperative society. So they may bring the snake, they extract the venom, and they send it back to its habitat. So that is how they work. So one important information, snake do not exhaust their entire stone of venom even after several strikes. So they are no less venomous after eating their prey. So small amount of venom may be injected in both adult and child. So that is one area where we need the same management for both adult as well as pediatrics. So there is no pediatric dosing for anti-snake venom. So snake doesn't know whether it's an adult or a pediatric. So it injects the same amount of venom. So you have to treat the child with a maximum dose of ASV whenever it is required. So there is not you just need 5 vials for an adult and 3 vials for children. It is not like that. So, and there is also a concept called as dry bite. So you need to be aware that dry bite is that even if the snake is venomous, it is not injecting the venom into the victim. So either because of the mechanical insufficiency or the snake's control of its venom discharge. So there is a concept called as dry bite. So you need to be aware of dry bite also. Going on to the next clinical effects of snake bite. Uh, so you can start off with the fang marks, and very, very important, those who are just new to this emergency medicine, you have to understand that crate and envenomation, they don't have, you will not be able to see any local reaction. Maybe you don't see the fang marks also, because the needles are so much hypodermic, you will not be able to see a fang mark. So whenever you get a patient with an unexplained acute flaccid paralysis, snake envenomation, neurotoxic snake envenomation should be one of your differential diagnosis, and always consider crate envenomation as one of the possibility. And the classical history, when I started my residency in emergency medicine long back, We just heard that crate bite usually happens inside the house, and it only happens after certain like 9 p.m. when the patient is sleeping on the floor. That will be the history that you need to ask in for. I thought it is just for the sake of being in the textbook. It is not a right fact, but whatever cases I have seen crate bite, it is a classical history that we have got. The bite has happened, the patient sleeping on the floor on the night hours, and there is no local reaction. We even remember it was just prior to our Onam celebration, we had a patient coming to the emergency room with an acute flaccid paralysis, being referred as a possible Guillain-Barré syndrome with a variant. But we were just intubating him because his airway was compromised. So we were just anxious. We were just asking history again and again, and we just asked the attenders to go and search the room again because it is not immediately we didn't do. It took 1 or 2 hours that we were just saying that it can be a snake bite, and attenders went back and checked the place where the child was sleeping, and there was a live crate. So this is not an. This is my real life experience. What I'm sharing with you, and they killed the crate and brought back to us, and meanwhile we understood, okay, it's a snake bite. We started treating the patient with neostigmine and all anti-snake venom, and within third day the patient is discharged and he's back home. So that is the magic that it can do. So history is again very important. So crate, that is very important. You don't have any fang marks, and the classical for other envenomation, you can have local pain, bleeding, local inflammatory signs, blistering, and lymphangitis, lymph node enlargement. Very, very, very important. Uh, you know, palarythrocyanosis clubbing, lymphadenopathy will be the last one. But when you get a patient with a suspected snake bite or with a snake bite, localized lymph node examination is very, very crucial because the initial spread of the venom is via lymphatics. So if you have some patient coming to you, you are having a bite mark or a fang mark on the that right lower limb, and you are looking at the inguinal lymph nodes. Initially, when you came in, there is no lymph node palpable, and maybe after 15 minutes, you are again palpating. You are able to feel a good palpable lymph node. That is the clue that this patient has got envenomation, and there should not be any delay in administering your anti-snake venom. So you have to be very crystal clear. It is one of the best clue that you can have is localized lymphadenopathy. Later on, you can abscess formation, necrosis, and compartment syndrome. So, as I told you, it is not poisonous, it is actually venomous. So, whatever be the picture that we got from Google, it is written as poisonous. But we should not be using that terminology. It is venomous and non-venomous. So, you can see the fangs of spectacled cobra, Russell's viper, and you see the common crate. It's pretty tiny, small one, hypodermic. So, you don't have any local reactions, and you can have the soft scale viper. So in real life, it is not that simple. So you can see the double scratch mark. It is a double scratch mark. It is not that classical two pinpoint. So just a scratch mark, and the patient had features of envenomation. Single bite mark. The patient had just bitten through the side, and only a single bite mark also is a possibility. So the classical double this thing you might not be able to see a single scratch mark. What you are seeing here, and severe local symptoms also what is being given in this picture. So symptoms: vomiting and abdominal pain, classical of Clayton and Russell's viper. So, whenever a patient with envenomation features, or you're doubting that this patient has got an envenomation features and he start complaining of abdominal pain and vomiting, take it from me. That is the first sign that the patient has got features of envenomation. So, vomiting, abdominal pain, you have to think about Clayton envenomation and Russell's viper, and bleeding tendency, Viperidae family, ptosis, ophthalmoplegia, neurological weakness, Elapidae, that is the Indian cobra and the common crate, but also in Russell's viper, you can have mixed hemotoxic and neurotoxic. Myalgia, stiffness, tenderness, trismus, myoglobinuria. You commonly see sea snake and some crate, and even higher grade of Russell's viper. If a significant amount of venom is injected, they can go for rhabdomyolysis, and you can have myoglobinuria, but not trismus. So coming to the renal failure, as I told, all Viperidae species, but specifically Humnose pit viper, you have to remember that it will have major renal failure, but no other hematological abnormalities. And pituitary and adrenal insufficiency, Russell's viper, just like we discussed regarding the Sheehan syndrome, where the bleeding has happened inside the pituitary. Similarly, you need to remember the Russell's viper, DIC, bleeding, thrombosis, again Viperidae, and hypotension and shock. Again, in hypotension in a snakebite patient, you have to be again very, very important. There can be multiple reasons. It can be initially due to the vasovagal syncope, be due to the panic attack. Second, it can be the venom injecting, and it can be cardiotoxicity related, or it can be due to your anti-snake venom therapy due to anaphylaxis, or it can be due to one most important thing you should not be forgetting regarding the bleeding into the adrenals, specifically in hemotoxic. So, like in septic shock, you might need to give in refractory septic shock, you need to give hydrocortisone 50 mg Q6 hourly. So you have to think that way also in when you are getting a patient with snake bite. So the syndromic approach, as we say, the right way to assess. So you have the syndrome number one. You have you need not look into the what the patient has been brought, whether they have brought the snake or not. Irrespective of that, you go ahead with the patient's clinical features, bleeding or clotting or local swelling. You have to think about Viperidae all species. So that is syndrome number one. Syndrome number two, you have bleeding, clotting, and there is local swelling, there is renal failure and shock. You have to think about Russell's viper or hub-nose pit viper. You have syndrome number 2 plus it is neuro hematological abnormality with dark brown nodule. It's 100% it is Russell's viper. So there is no doubt it is Russell's viper. This is the classical picture that you see the ptosis here. So syndrome number 2 with conjunctival edema and acute pituitary insufficiency. Again, it can be hematological abnormality, hematotoxicity due to Russell's viper. Syndrome number 3, there is local features of envenomation and there is neurological features. So it is elapidae, but in elapidae, Indian cobra. But as I told you, you don't have a local features in crate envenomation. So syndrome number 4, you are seeing there is no local swelling, absent fang marks or faint fang marks, sometimes bitten on land while sleeping indoors and with paralysis. You have to remember regarding crate. And finally, the same bitten in the sea. Again, it can be a sea snake. And syndrome number 5, you have paralysis with acute renal failure and dark brown nodate bitten on land. Again, it is Russell's viper. So this is a syndrome. It is very simple. It is not complicated as what you see. Hematologically, you think about Viperidae family, and you have hematological with neurological, you think about Russell's viper family, and you have primary neurological with no local features, think about crate, with local features and neurological manifestation, think about cobra, Indian cobra. So that is the normal presentation that what we see. When the patient don't have any other clinical features, you just need to observe the patient. So this is a flow chart being taken from the WHO. Whatever I'm saying is from the WHO guidelines, which is being specifically made for the Southeast Asian region. So this is again self-explanatory. You can go through this flowchart later on. So it's not that difficult. Whatever the symptoms that I have told you is being covered in this flowchart. And there is some specific terminology called as cobra spit ophthalmia. So you will have the venom is getting sprayed into the eye, specifically due to the cobra. Immediate, there will be intense pain, profuse watering with whitish discharge, congested conjunctiva, spasm and swelling of eyelid. Now coming to the stages of management, again, you have to start off with the first aid, transport to the hospital, rapid clinical assessment and resuscitation, detailed clinical assessment and specific diagnostics, investigation and laboratory tests, and antivenom treatment, which is the cornerstone in the management, and observing the response to the antivenom, and going on deciding whether further doses is required or not, support and ancillary treatment, treatment of the bitten part, rehabilitation, treatment of chronic complication, and advising how to avoid further bites. So this is the total flow chart that you need to take care for a patient with snake bite. And coming to the first day, there are a lot of misconception, what to do, what not to do. It's very simple. Do it right. Reassure the victim and don't delay to take him to the hospital. So get to hospital as early as possible. Meanwhile, you can immobilize the bitten limb. So how to immobilize? There has been few controversies even within the India. There are some people you need not do anything around the wound site. Just bring with an immobilizer to the hospital. Some people say that you need to wrap it around with some cloth which is available. If it's a crepe bandage, it is well and good, but it should not be that tight so that it blocks the arterial supply. It should be just tight enough so that the lymphatic supplies are stopped. So if you are able to teach that to your patients, that is well and good, but it's very difficult because every other patient that is coming to the emergency room, they will have something called as tourniquet. So we'll come to the tourniquet. So personally, do not attempt to kill as the snake, as it might be dangerous. And do attenders need to bring the dead snake to the hospital? The answer is always very clear. But there are certain circumstances, if they are getting a picture and you know that it is hub-nose pit viper, there is no point in giving ASP. So in areas where it's hub-nose pit viper is very prevalent, you can maybe you photograph, you can think that the ASB is not going to work. So you're not wasting a resource. But otherwise, you don't have any clue, you don't have anything else. You need to go ahead with the clinical features and you need to manage the patient. So recommended first aid, reassuring the victim and immobilize. There are a lot of methods by which by pressure pad plus immobilization or pressure bandage immobilization, where you're just wrapping around a crepe bandage or a small cloth, and you're allowing one finger to be one finger you should be able to insinuate in between. So that should be the tightness by which you should be doing this. And you carry to the hospital. So there are various modality, and two-wheeler is one modality that the patient comes to the hospital, because usually this happen in a rural area. They need to rush to the hospital, and always make a list of hospital where you have the anti-snake venom available. So don't waste time by bringing to a patient to a hospital where there is no ASV. So the most traditional methods should be discouraged. They do more harm than good. So avoid any interference. No tourniquet. So no tourniquet, no tourniquet, no tourniquet. So measure the tourniquet. So what is the problem when you have a rapid release of tourniquet? There is a sudden gush of venom into the blood, and the patient can deteriorate and die. So that is a one major challenge that that we need to keep in our mind. So what you ask me for evidence, there is no evidence access, but what we practice for since last so many years is what you apply the BP cuff above the tourniquet and you take it to the systolic blood pressure, the BP cuff to the systolic blood pressure, then you release the tourniquet and then you slowly deflate the cuff maybe within next 10 to 15 minutes. So that whatever be the circulation that is revamped and there is no sudden entry of venom into the circulation also. And also when you have other features of envenomation, when very sure that the patient has lymphadenopathy, the patient has got blistering and the patient has hematological abnormality, immediately you start anti-snake venom also. So you are releasing the tourniquet, immediately you start off the anti-snake venom also if you are very sure that there are features of envenomations is there or not. So, so coming to the ABCD approach, airway breathing, we all know, but one key thing that I need to tell here is the single breath count. So, just like for our Guillain-Barré syndrome or myasthenia, you need to ask the patient do a single breath count and make a note of it. Now it is 35, and after like 15 minutes, it has come down to 25, which is very, very significant. So, you need not wait further. You can start treating the patient with your anti-snake venom. Coming to the 20 minutes WBCT. So 20 minutes WBCT is a test where you can do, there is no harm, but there are certain prerequisites. You need to have a clean glass container. You should not be taking a glass container, cleaning then there, and you should not be using. It should be available before. It should be dried and should be available before. So you can take a 2 ml or 3 ml of fresh blood and keep it 20 minutes apart and you see whether the blood is getting clotted or not. If there is no clotting, you have that the patient has gone into DIC. So you can start away, straight away start your anti-snake venom therapy. But you have to be very specific. 20 minutes WBCT. If you have a center where you can do a PTNR between next 20 to 30 minutes, that is the gold standard. 20 minutes BCT, maybe you can do, there is no harm. But if you have PTNR, that is very good. Why? Because this is the reason. PTNR, even if the coagulation factors are getting deranged with 10 to 15%, the PTNR will start getting elevated. But if your 20 minutes WBCT, you need at least 30 to 40% of your coagulation factors to be deranged to start getting elevated. So PTNR will be a gold standard. When you have availability, no point of care PTNR, because there are a lot of Australian studies, they have found out that PTNR that has been done at the bedside, and even with my personal experience, PTNR taken at the bedside with the point of care devices, it gives a false value. So don't use a point of care PTNR. You do the lab test, and if you're able to get the result within 20 minutes, that's well and good. So what I used to do, I used to send one person and call the lab person and tell me that I got a snake bite patient, so I need a PTNR result within 20 minutes. They will give me the result within 20 minutes. So that technically, if the equipments are all very good, you can get it within 20 minutes. It's not that maximum, maybe within 30 minutes you can get. So meanwhile, you are having a 20 minutes WBCT. When two or three people are looking and shaking and seeing whether it is there or not, there is no confusion here. PTNR, you are getting a lab report and it is elevated. You straight away start off your anti-snake venom therapy. So again, the anti-snake venom therapy, what is available in our country is the polyvalent anti-snake venom. So it works well against the big four, whatever we have described. So each ml will neutralize around 0.4 mg of the source scale vapor and 0.4 mg for your common crate and 0.6 mg for your common cobra and 0.6 mg for your Russell's Viper. So that is the calculation. Suppose you give 10 ml, 6 mg of the Russell's Viper venom will be neutralized. So that is the calculation. So again, how with and what is the maximum dose? So again, it's a big area. So when you decide to start, what they have found out from animal studies that on an average, the maximum amount of venom is injected by the Russell's Viper. So on an average, it injects around 63 mg of venom. So to neutralize that 63 mg, you need to have 10 vials of anti-snake venom minimum. And the maximum what is being recorded is 147 mg. So to cover that 147, maybe you can take up to 180 mg. Maybe as a different, maybe the snake is little bit, the clinical features are more. The maximum what we see is 147. And from animal studies, maybe you can go up a little bit higher and 180 mg can be covered with 30 vials. So 25 to 30 vials will be more than sufficient to cover whatever be the venom that is being injected by the snake. So how much you should start off with? You start with 5 to 10 vials, depend upon your clinical features. You think that it is a Russell's Viper, clearly it's a hemotoxic, you can go ahead with 10 vials. Again, the maximum is what is recommended is 25 to 30 vials. So there is again and again, it's very, very important when to give your anti-snake venom. Fag marks with rapidly spreading local swelling with tender nodes, hemostatic abnormality, you have neurotoxic signs, you have shock hypotension, you have oliguria, RFT getting elevated, rhabdomyolysis features, you can just straight away go ahead and start administering your anti-snake venom. And there is no test dose. I have tell you the maximum dose and the minimum dose. And anaphylaxis is again one of the major factor. But if you have anaphylaxis, you have to treat. So this is one area where we classically teach that when you have an anaphylaxis, you stop the product again. But this is an area where we have to say, you stop, restart. We had a patient recently where we were giving adrenaline through one line and we were continuing, we stopped taking the anti-snake venom through the other line. So now, how to give the anti-snake venom? There are two methods by which you can give in. One is the push method, which I prefer to use. You take the freeze-dried powder, you reconstitute, and it will become 10 ml. So 10 ml. So you have decided to give 10 vials, so it will become 100 ml. So 100 ml you need to take into the syringe pump, and you can put it in a syringe pump, and you can give it a rate of 1 to 2 ml per minute. So that is one method of giving this. Otherwise, you can take the whole 50 ml or 100 ml, you dilute it further, but whatever be the dilution, the whole anti-snake venom have to be completed within the next 2 hours. You should not be giving it prolonged. There is no like one vial of anti-snake venom TAD. That is not the dosing. So whatever be the venom that is there, you are trying to neutralize it as early as possible by giving the anti-snake venom as early. So there is no like you give 3 vials now, 3 vials in the afternoon, 3 vials. There is no business like that. Whatever you wanted to give, you give it at that moment itself. You decide that you give to 10 vials, you maximum within 60 to 100 minutes, you need to give it. Whether it's a push method or it's a dilution method, whichever it is comfortable for you, whichever is working for you, you can use. But there is no test dose. You have to be prepared for anaphylaxis. Again, there has been previously we used to give pre-medication with steroids and all those things, but right now there is no pre-medication. If at all there is a high risk of anaphylaxis, previously maybe you can give 0.4, 0.3 to 0.5 mg of adrenaline IM prior to that. So there is no pre-medication with hydrocortisone or Adil, because the steroid itself will take you at least 3 to 4 hours to act. So there is no point in giving and pre-medication prior to giving your anti-snake venom. So it is clearly given the guidelines. If at all you want, there is a strong Sri Lankan study where they emphasize if you want to give a pre-medication, you can give it with adrenaline 0.5 mg IM. And when you want repeated doses, so that is again a big challenge. So you have started off, you have given your initial 10 vials within the first 2 hours. Later on, when should I repeat? That has been an important question. So when you should repeat the next dose of anti-snake venom? So one thing, if the patient is clinically stable, you can wait, and after 6 hours, you recheck your PTANR. You see what is happening to your PTANR. Why we are waiting for 4 to 6 hours? We are giving liver to replenish whatever be the coagulation factor that was being depleted by the venom. So the liver need time to reproduce these factors. So you wait it for another 4 to 6 hours, and then you send your PTANR. So that is one important thing that you need to keep in your mind. Or 10 vials, still the patient is having neurological weakness, or still the not wait. You continue another 10 to 15 ml, 15 vials, and maximum of 25 to 30 vials. So you have to be very clear how much is the maximum dose, how much is the minimum dose that you wanted to start off with. 5 to 10 vials to start off with, and maximum not more than 25 to 30 vials. And when to give is very, very important. So that is what I have been telling you. You have to be with the patient. You cannot move away from the patient. You have to be with the patient. See him how he is responding or not. Then other part, neurological weakness, you have physostigmine, and you have to give atropine, because physostigmine can cause bradycardia. In order to counteract, you can give atropine. So for crate envenomation and cobra, that is the additional thing that you need to add on. You need to add on around 1 to 2 mg of physostigmine and 1 mg or 0.5 to 1 mg of atropine. You pre-treat with atropine so that there is no bradycardia with physostigmine. There has been some centers which they have managed cobra bite without anti-snake venom, but you are very sure that it's anti-snake venom, it has succeeded for them. But I don't advise that, because you have got an anti-snake venom which is available, so you can go ahead and give that to the patient. So if you don't have it available, then that is a problem. Then you can manage with physostigmine and atropine and maybe just with ventilation, but that won't work for crate, because it's a presynaptic toxic and it will kill all the nerve endings. Postsynaptic, okay, it might, but not for your crate envenomation. So neurotoxic envenomation, that is the additional. And still the patient is bleeding. That is the time when you can think need for your blood products, and maybe your FFP, cryoprecipitate, and all those things you can think over. And there can be problems with resistance of anti-venom, because as I told you, we are just taking venom from one geographical area and we are producing the anti-snake venom with that. So there can be challenges, there can be resistance being reported. So these all things are issues with the current anti-snake venom. So what we are recommending, regionally sourcing. For a state, you should have an area where you are developing your own anti-snake venom. So you're taking the snakes from your geographical area and you're preparing, because it's a big challenge. It will not work out, because none of the pharmaceutical companies are very much interested in this, because it's a lot of issues happening regarding snake bite, because a lot of wildlife activities, everything will come together, and it's a huge challenge. But it is very important that facility to have a local for geographical production of anti-snake venom and dialysis. Yes, when you need to go ahead with dialysis, the standard indication. And there has been a lot of things regarding cytosope therapy. Cytosope therapy is like you are when the patient can go into something like an HLH, or the patient can go into a cytokine storm suddenly due to the rapid release of the inflammatory markers. And we had 3 to 4 patients where we have used the cytosope therapy and we have bring down the cytosope. Maybe you have given your anti-snake venom, but the later on the inflammation, you need to bring it down. The cytosorb can help. So that is one thing that is upcoming, and many of them, if you don't have cytosorb also, even plasmapheresis is also good. There are a lot of centers which they have started doing this with cytosorb sometimes and with plasmapheresis also. And for other inotropic and vasopressor medication, and definitely ventilatory support is very, very crucial. So tissue loss, amputation, chronic ulceration, all those things. CKD, chronic panhypopituitarism, that has been a challenge with, especially with hemotoxic envenomation and post-traumatic stress disorder, and all those things are very, very common. But what is the syndromic approach, and because the time span is very short, so that I thought I'll just give you an overview of what needed to be done in case of a snake envenomation. And the key point, the takeaway points is that you have to be with the patient. A good history is always important, and do it right as the first aid. So try to spread this message wherever it is possible, and be with the patient when you're treating with anti-snake venom. Don't jump and give your anti-snake venom. You look at the patient, and if he has any of the syndrome like what we have described, without any hesitancy, you need to start anti-snake venom. It is not that big deal. We are dealing many other emergency. It is not big deal to give anti-snake venom. Many of the doctors, they feel that they don't have that confidence in venom. So when you're doing a cardiac arrest resuscitation, there is nothing bigger than doing giving an anti-snake venom therapy. So you should have enough confidence, and don't over give anti-snake venom. 25 to 30 ml is more than enough as per the current evidence. So stick to the evidence and guidelines and start treating the patients. So if you have any questions, I will be happy to take that, because I've been given just 30 minutes. I have just stick to that 30 minutes.
Yeah, thank you very much, sir, for an elaborate session. And
Yes,
we all saw the enthusiasm and your interest in this topic also. So you were
yes.
like unstoppable. So really appreciate your efforts, sir. And this
Thank you,
is the
man. Thank you.
last episode of this season, or whatever we are calling this learning experience.
Yes,
So because of this, I wanted this to be a special episode, and that's why I invited you for the talk. And I'm
thank you.
really happy. And the PPT also, if you can share it with our
Definitely, definitely. There
students.
is nothing for me. It is all for everyone. I always
Yes,
does
sir,
that.
of course.
Yes.
So, and we'll take some questions. There have
Yeah,
been some questions posted here.
sure.
So,
I will
patient
be.
presenting with seizure after snake bite, what do we do?
So just like that, the seizure, it can be, you need to definitely differentiate whether it's a syncope versus seizure. So that is the first. Mostly it can be a syncope episode. Seizure, just like that, any other patient that you manage, and simultaneously you manage the snake bite also. There is nothing specific to snake bite that you should be doing, not doing, but you just need to keep in your mind that it can be a syncope. It not be a true seizure that you are witnessing. But if it's definitely a seizure, you need to manage. But again, it can be challenging for you to decide whether to give your anti-snake venom or not. So you need to look at your other parameters. You need to look at your blood parameters for a hemotoxic. Definitely the neurotoxic features, you need to look in for any local signs or any of these things. If these things are there, yes, you need to go ahead and give your anti-snake venom and treat seizure separately. But we had patients, we always think about hemorrhagic complications. We had a patient who had presented with acute stroke with seizure, because DIC, it is not just bleeding, it is thrombosis also. So we need to manage how you manage a thrombotic stroke on the one hand, but the priority comes initially to treat the with the anti-snake venom, followed by the management of stroke. So that is the answer for that. Next one.
So, somebody is asking, what are your views on anti-venom induced myelopathy in a semi-poisonous snake bite? How to deal?
So there is nothing like a semi-poisonous snake. Either it is venomous or non-venomous. That's the first statement that I have made. Either it is venomous or non-venomous. So venomous, there are big five what you have said, but king cobra, yes, it's venomous, but it's not that creating medical problems for our community. Unless you go and play with around, you can have problems. But king cobra, even if it come to a habitat, it never have any of these things. But anti-snake venom induced myelopathy, anti-snake venom, just like our vaccine, any of this vaccine, there has been case reported where vaccine has been given and patient had complications related to the vaccination. But it's again here, vaccination is an option, but here it's an option of between life and death. If we are very sure that it's a venomous bite and the patient is going to save with that, you have to go ahead and give the anti-snake venom. So we are not worried about the even the worst complication of anaphylaxis. We are not worried. We have to give anti-snake venom because that is the only option for us. So whatever the myelopathy, I have never had any cases reported to me after giving anti-snake venom reporting myelopathy, but definitely it can happen because it's all the same product. It's a vaccine generated. Vaccine can create myelopathies, also can create. But to my knowledge, there has been never a case been reported.
Yeah, sir.
Repeat those. Yeah. Okay.
So this when to give atropine neostigmine before or after ASV, the role in a crate bite. I think it was covered.
Yes. Yes.
Yeah. So usually, also you have also mentioned that even if there is an anaphylactic reaction, we have
Yes.
to continue to give the
Temporarily we
ASV.
can stop. Yeah.
Yes,
Temporarily we can
but
stop. But after giving
uh,
your
and
adrenaline
if it
one
is
shot,
not subsiding, also I think we have to intubate the patient and we have to control the airway, and then
yes.
with all these supportive measures, we have to continue giving the ASV because that is more important. And is that right, sir?
Yes. Very true. Very true. Very true. Very
Yes.
true.
So I feel that is something which emergency physicians are more. That's why snake bite management and toxicological management is more specialized for our emergency physicians because
Very.
we are not scared we have airway in control and circulation in control, and we are not scared of any such adverse events in managing these patients. So I think
Yes.
compared to other specialities, it would be giving us an edge. So,
Yes. Very true.
so yeah, thank you very much, sir.
Yeah.
If
Thank you,
any
Nayan.
other questions, I think you can directly reach out to sir
Yes.
in working hours, of course.
Yes.
So,
Definitely. Not an issue. I'm always
yes, sir.
available
Yes,
through
yes,
a message or a call for you.
right, sir.
Yeah.
Thank you very much, sir. Thank you
Thank.
for coming, sir.
Thank you,
Thank you.
Nayan. Thank you, Dr. Logendra, and the whole family of SACTEM for giving me an opportunity to represent the SACTEM family on behalf of everyone. Thanks you once again.
Thank you, Shri. Thank you so
Thank
much.
you. Thank you. Thank you.
Thank you.
Okay, sir. Bye.